My name is Emiliano Reinares. Good morning, first of all. And on this session, I'm going to present the result of our research related to an assessment of the quality issues on mappings between these two specific vocabularies. Andres Splendiani and I developed this work, and as we work on the IQVIA Center for Health Data Semantics. And our aim was to provide a first quantitative assessment on the impact of neglecting provenance details on the mappings between two specific vocabularies. And bear in mind that by using the wording of a vocabulary, I refer to a broader set of artifacts going from coding schemes, terminologies, taxonomies, and also ontologies. So under this umbrella of vocabulary, I refer to ICD10, SNOMED CT, MEDRA, even the Monde ontology could be considered a vocabulary. So along this talk, I'm going to describe the value of mappings, also how are they used on the real world, some evidence available in the literature in previous work related to similar studies. I will explain the differences between the semantics as described, the semantics of the mappings as described on the different sources that we consider for our comparison. The result in terms of numbers and also some samples, not only of the mismatches on the mappings, but also plain errors that we found on one of the sources. Well, I will end up with the conclusion, the future lines of work, and of course the Q&A session. So we know that at the end we need of medical vocabularies because we need a way to standardize how we understand and how we used a clinical and a biomedical concept. And they are needed because they serve as a way to make interoperable the healthcare systems and also to perform data integration and to share a common understanding between the professionals. But at the same time, we know that because of a set of reasons, going from historical reasons, operational ones, even reasons related to compliance issues, different clinical and also research workflows use a variety of vocabularies. So vocabularies were created to enable integration and interoperability, but at the end, this variety, this availability of different options prevents of a real integration. So that raises the need for mappings to overcome this issue. And we know that there is a contextual and dynamics aspect related to these mappings between vocabularies because the vocabularies evolve. As somebody mentioned before, vocabularies evolve even across versions, and the mappings evolve or should evolve at least. And we also know that the mappings have a goal to be created. So there is a set of assumptions that at least at the end result on a set of different approximations between two different vocabularies. And in this work, our intention was to quantify the impact of these different assumptions. And although this impact, in this case, we analyze the differences between two different sources. The reason to perform this study was to assess the prevalence of those issues. So how much of these differences are respected to the overall mapping set. And we can find anecdotal evidence on the literature related to the existence, the recognition of these issues on the quality of the mappings between vocabularies. There is, for instance, work related changes in the terminology with research breakthroughs, also with policy changes, and also to shift in public health priorities. There is another study evaluating the complexity of mapping information across vocabulary because of the lack of up-to-date information, but also differences on the granularity between the source and target vocabularies. Another work analyzed the difficulties on ensuring that the different vocabularies reflect the latest medical knowledge. And there is also a lack of information on how, when, and why the mappings were created. Basically, there is no provenance details on the mappings on itself. Another work analyzed the semantic ambiguities of cross-references between ontologies that even belonged to the OBO foundry. Another study analyzed differences in granularity, but also in the focus on mappings between METRA and ICD from two different but well-recognized sources, like UMLS and the OMOP Common Data Model through the OHDSI standardized vocabularies. And finally, we found a work analyzing the challenges that are generated by the semantic drift, because at the end, the meaning of the terms evolves over the time. So in the same vocabulary, there are inconsistencies across versions. So we decided, again, to quantify the impact of these discrepancies between mappings retrieved from different sources. And to do that, we compare the mappings between these two vocabularies I mentioned before, ICD10 and SNOMED, from two sources, the OHDSI standardized vocabularies and the SNOMED standard release. So in one hand, we have ICD10, which is developed by the World Health Organization. It's a vocabulary for coding diseases and symptoms, and is used for reporting purposes. On the other hand, SNOMED CT, developed by SNOMED International. It's a clinical terminology that is used for healthcare documentation. And we decided to use these two vocabularies for our study because the mappings between them are very well established, basically because they serve complementary purposes. So they go from clinical documentation to billing, and also they are used to perform statistical analysis. So these are our two vocabularies. Now, speaking about the sources, we retrieve one set of mappings from the OHDSI standardized vocabularies, which is a repository implemented through the Athena system that is used by the latest version of the OMOP Common Data Model, the version 5.4. And on this repository, we can find mappings relating code from ICD10 in the release 2021 to terms on the 2024 February release of SNOMED CT. And that's one of the sources. The other one is the SNOMED official release. And in this case, we found mappings related concepts from 2024 June release of SNOMED CT to the 2016 release of ICD10. So here we can see the different specific versions that were used in our analysis. But it's also important to recognize that they call mappings to different things. On the left side of the slide, we can see that OHDSI, actually the OHDSI standardized vocabularies, describe mappings as a set of equivalencies. So basically, the source and target concept have the same meaning, and their descendants cover the same semantic space. And in the case such an equivalence is not possible to be defined, they used the broader SNOMED code to be mapped to the source ICD10 code. And you can see an example here. They mapped, when there is no equivalence, in this example, they mapped bitten by goose, ICD10 code, to the peck by bird SNOMED concept. And we can see clearly here the difference on the granularity because there is some portion of the context of the situation that is not represented on this mapping. On the other side, we see what SNOMED consider a mapping, and they don't have a single unified definition for mappings. They have 8 different types of mappings with different semantics. They go from mappings of a source concept, which are context dependent, to source SNOMED concepts, which are incompletely modeled. So given these differences between the semantics of the mappings, we needed to filter out the mappings to compare. And we decided to take a conservative approach. Basically, the mappings we consider should fulfill three conditions. First of all, they should relate an ICD10 code to a single SNOMED concept. The mapping should be active on the OHDSI standardized vocabulary repository. And also the mapping should belong to the category number 4 on the SNOMED official release. So the mapping should represent map source concept, which is properly classified. And we know this approach is pretty conservative in the sense that it overrepresents the simple cases. But at the same time, we needed a common ground to compare how the mappings are used with a similar semantics on the practical usage. And here we can see the result of our comparison. We see that OHDSI standardized vocabularies define more than 18,000 mappings between ICD10 and SNOMED, while the SNOMED release define more than 123,000 of those mappings between SNOMED and ICD. But out of them, there is an overlap of more than 1,700 ICD10 codes, which are mapped to a single SNOMED code. Out of this subset of overlapping ICD10 codes, more than 1,200 have a map that does not present any difference between sources, so they match. But almost 500 of them mismatch, present some kind of difference. In flat numbers, roughly speaking, 27.5% of the mappings over this overlapping set present some kind of mismatch. And then we decided to categorize, to identify at least the different reasons for this mismatch. And we found 4 different buckets, and a last one in gray here, representing the 37% of the mappings, which requires further investigation because we couldn't find a logical reason for the difference. But of the other ones, there are these 4 buckets, and 47% of them present a difference on the abstraction level. Then next, we'll see some examples to clarify these categories. And 10% of these mismatches are due to variation on the semantics of the term. So basically, the different sources understand the terms on different ways, and that's the reason they create different mappings. There is a 4% of mismatch because of the evolution of the vocabularies, and 2% of them are just plain errors. And we assume or think that perhaps it could be due to a bug on the workflow that implement or store the mapping into the repository. And on this slide, we can see an example per each of these categories. On the table, on the left hand, for each ICD10 code that is mapped in a different way by the 2 sources, we can see how those sources defined the mapping target. The first row for each of the ICD10 code describe the mapping proposed by OHDSI standardized vocabulary. The second row describe the mapping proposed by SNOMED. So for instance, in the first row, we see that the other specified salmonella infection is mapped to salmonella infection by OHDSI, but is mapped to invasive non-typoidal salmonellosis to SNOMED. And this is a different, this is an example of the mismatch because of differences on the level of abstraction of the mappings. In the second row, we see an example of mismatch due to different semantics. In this case, the mapping target belongs to the same branch, but they are not exactly the same concept. They are siblings. So the sources of mapping are understanding the concept on different way. The example that I'm showing here is the ICD10 code referring to zoster encephalitis, which is mapped to herpes zoster encephalitis by OHDSI, but is mapped to herpes zoster myelitis by SNOMED. And in the last row, we see an example of a mismatch that is generated by the evolution of the vocabulary. So the ICD10 code about paniculitis affecting region of neck and back, cervical region, is mapped to paniculitis of neck by OHDSI, but is mapped to inflammation of subcutaneous fatty tissue of neck and thorax by SNOMED. And we can also find, we can also recognize plain errors, these 2% I mentioned before. And this is the list of ICD10 codes that are being mapped by OHDSI to SNOMED concept that actually don't exist. So they are just bugs. These numbers don't exist on the different releases. So in our work, we compare the mappings available on two different sources between these two vocabularies to understand the effect of neglecting the temporal, contextual, provenance details of a set of mappings when using on the real world. And in our analysis, we found a relative significant number of mismatches of around 30%. And we can see that at least 1/3 of them are due to different level of abstraction. And this is reasonable given that the different sources for the mappings are aimed to different kind of processes. One is more related to clinical versus the other one that is more used for population studies. 4% of them are, of these mismatches are due to term obsolescence. And this was surprising. We consider that this number is pretty high because the releases of the different set of mappings is synchronous in time, even when there is a discrepancy of a few months between the vocabularies that are being considered for the mapping. And the 2% of plain errors also surprised us. We expected to find no error, specifically on the OHDSI where there is a very structured workflow to define the mappings. So here, we presented this comparison. Our intention was to provide a first quantitative assessment of this impact over the quality of a data set that is the result of a data integration process. And we think that these numbers provide are a proxy for the impact on the quality of the resulting data set, and we could quantify this impact on the order of 20%. Also, it's important to realize that at the end, the usage of one set of mappings or another one could be arbitrarily defined, and that could create quality issues on the resulting data sets in terms of a lack of coherence between how the terms are used. We have these 4 feature lines of work going from a deeper inspection of the reason for the mismatches, where we couldn't identify a reason. We plan also to extend the analysis to other vocabularies and to other sources. And instead of using the analysis or the comparison of mappings as a proxy for the quality on the resulting data set, another potential work could be to actually inspect the different way that the terms are used on actual data, on deployed data sets. And that's all. Thank you for your attention. Also, I wanted to mention that we are open for collaborations on the feature lines of work I mentioned before. So if you are interested, reach out on the break, on Slack, on LinkedIn, or send us an email to ontologies@icubia.com. That's all. Thanks.
Hi, thank you both to this talk and the previous one. It's less a question, but a thought. I keep thinking, what is more efficient? actually trying to bring these vocabularies together better, or constantly building new mapping models, which with every application have to be renewed, every release of a vocabulary need to be run again, and it's really hard to implement, especially when you don't have a bank of developers and DevOps experts to put that into biological applications for our R&D users. It's more pondering. If anyone wants to talk about it over coffee, I don't know if you've got an answer or Shervin has an answer to this.
Well, actually, I don't have an answer because I don't see any specific question, but I agree that there is an inefficiency on the way we define the mappings, we maintain the mappings, and we use the mapping. AI, I think that could be used as a way to tackle some of these inefficiencies. At the end, it's always needed human curation to keep the scientific quality of these mappings. But I think that we could use a set of tools to tackle those inefficiencies. For instance, by starting to adopt, to really use the standards that are available to describe provenance details of the mappings. Because when you go to OHDSI standardized vocabularies or to go to SNOMED, there are no details of provenance on the mappings on itself. You need to read the documentation to understand what is there. So first of all, start adopting the available standards. There is no lack of standards. There are many of them. We just need to start using them. That's the first obvious step. Second one, we could leverage some of the new tooling to automate, at least in part, the definition and maintenance of these mappings. That's my take.
Hi, I will be giving a talk later, but one of the things that interests us is also customization. So it's not only coping with time, like, over time there will be different versions of SNOMED CT, or UMLS has 2 releases per year, so time is always there. But what about our end users? Yeah, sometimes they wanted to use a particular term that is not exactly what is the preferred by default. So please come to the talk, because I would like to open to you what we have been doing, and hopefully, we can tackle together in a more sustainable way. But keep in mind that it's not only time, it's the end users that they expected us to customize to their needs or to their preferred terms. How we do that is the same problem, really, if you think about it. Yeah, allowing multiple versions and how we deal with all this massive explosion. So thanks for not an answer yet, but ongoing.
Thank you. I have a question about the obsolete terms, so the differences found due to the obsolete terms. Are these terms actually deleted from the vocabulary, or they still exist, just marked as obsolete or deprecated? So the mappings are broken links, or they exist just pointing to an obsolete term?
You refer to the plain errors slide?
No, to the previous one with the 4% of obsolete terms due to the evolution of the vocabulary.
Well, some terms basically disappear from the vocabulary across versions. Basically, this range and this time window is what creates those differences between the mappings retrieved from the 2 different sources. Even between monthly release on SNOMED, you can find differences. And if you don't have an automated way to reflect those changes on your mappings, your mapping is not valid for the new version of SNOMED, and that's what is being described on this example. So they improved the quality of the new release of SNOMED by adding the term that was missing. They removed the previous one because it was further specified, and the previous one was not required anymore, but the mapping was outdated.